move on to the next one. So I'm going to introduce Katie Becker, who is a nurse practitioner at Mass General Hospital. She's going to talk to us a little bit about the topic of transitioning care from pediatric to adult. So she'll bring up some of the issues associated with that transition and ways to confront that as a family. Here is Katie.
Yeah. Okay. So I've been told to try to go quickly. So I have no disclosures. Okay, so I started this with kind of trying to define the transition of care. It's a very new topic because fortunately, in the last 25 to 30 years, people with traditional pediatric illnesses are living longer and thriving into adulthood, which has caused the need for this transition. And the reason I put this quote up here is because it says the purposeful and planned movement from adolescence to adulthood. And I think that many of us as adolescents, as adults, and as providers sometimes feel that that transition kind of creeps up on you, and out of nowhere, all of a sudden you have an adult, and we don't do a great job of that. And then the next thing is, why do you need to transition? So many people are happy to always stay with their pediatric providers. So the first is that in pediatrics, we often say that children are not just little adults, and the same is true for adults. They're not just really big children, right? And so they have different medical needs. And also the big thing is that they now get to make the decision, not the parents. And then of course there can be physical reasons. Hopefully they move out of your house. Maybe their pediatric hospital won't accept them anymore. And then in ALD, I think has been well described today, the disease itself is very different in adulthood than it is in pediatric. And so I just put some history here. So you can see that really this idea of transitions is very, very new and has really only been discussed since the early 90s. And so out of that work, they have this very complicated, I think, timeline of how you're supposed to transition care, which begins when your children are 12 to 14, which seems young, but I think it's really because we have to change the dialogue in our appointments and transitioning them to being the decision makers. So I'm going to share with you one story, and this should probably be my actual disclosure page because that's a picture of me, the one in the white shirt. And so I am not a role model for how to transition your care into adulthood. So when I was a child, I was diagnosed with a congenital heart defect, and I underwent what I believed was corrective surgery. And I went to appointments like our boys do, and I got my echo every year, and I was just a stellar patient until the age of 18. At which time, I decided just that wasn't really important because I was doing great. And so despite having received excellent care and being in a nursing program and then in a nurse practitioner program on a pediatric cardiac floor, I just thought that was really not necessary. And so when I finally did go back, I learned a lesson that I think some of our men learned, in that it was not the best idea. Because shockingly, my echo was not normal, and we had no idea, did that just happen? Or was that long coming? And despite all that excellent education, I didn't even know what defect I had, which was embarrassing. And unfortunately, it's not actually that uncommon. And so as I think we all know, there are complications to not going to the doctor for long periods of time. And for many patients, those complications are longer lasting than the complications I had. And so especially men, if you have an advanced lesion, you cannot have some options. And the other thing I want to mention as a mom is that I remember when I did go back to the doctor feeling very mad at my parents, who are fabulous, and at my doctors. And I really felt like I can actually remember screaming at my mom, like, I was just a kid, why didn't you tell me this? Like, I should have known that I should have been going to the doctor. And she probably should have said, I paid for a really good education and they should have told you, but she was very nice and felt guilty about it. And I don't want, our patients to feel that, because I did feel angry. And I think as parents, we don't want to feel like we're ever letting our kids down. But the only way to do that is to give them the information and to begin to transition them to knowing that full information. And so the reality is, I'm not sure what I said here. Oh, I think that, okay, so the reality is, and this slide is to make me feel better, that the majority of patients don't have a good transition plan. And so even all these years later, only 17% of patients with a chronic illness have a full transition plan. So I'm far from being abnormal in that sense. So this is just to give you a sense of what the physical plan can look like, right? And the point here is that regardless of if you're staying in the same hospital or even if you're staying with the same provider, you still need a transition plan. And the reason for that is that I saw as I was doing this research in the last few weeks that really the biggest change for most adults, regardless of where they go to care, is the same thing I remember. All of a sudden, you're the only one in the room. And people are looking at you like, what's your history? And you have no idea. That's not good. And so it doesn't matter, right, if you're at a new hospital or not, you're still the only one in the room, hopefully. Or I don't know if that's hopefully or not. And so some specific transitions to think about. So the first thing is that some of our men or adolescents, are they able to take over their care completely? Some are not. And so that's one of the first things. And so most of these slides are going to talk about patients who are able to take over that care. And then what symptoms do they have? And then this is kind of like the big unknown in the room, which is what do we do for these women? So we know that we stink at transitioning patients that we see in clinic. So how do we begin to transition patients that we're not even seeing, right? Because you have all these women that we're saying you don't need to come to clinic until you're an adult, but how can we get them into clinic, and do we even have plans of care for them? So in the last several years, there are lots of models on how to transition care. And so this is a model showing where you have one specialty provider. And this actually looks kind of complicated to me. But this is really not realistic for a patient with AMN or ALD. This is more what their picture looks like, right? And this is probably a simple situation. And so I got frustrated even attempting to draw the lines of communication. So I think it's actually a wonder even more men are not lost to follow-up because they're left in this position where they have to get all these people to talk to each other and understand this disease. And so because this meeting is about pipe dreams and what it should look like, not necessarily what it does look like, I think that there's a strong argument to be made that those centers of excellence are even more important for men than they are for children. Because first of all, you're on your own all of a sudden, right? And second of all, men tend to need more care, I think, and women. So at this time where they're transitioning, they may also need a urologist. They may also need physical therapy. And so I think that the only way to realistically expect this to happen is to have adult centers of excellence. And so this website, I want to make sure I mention, Got Transition, is an excellent website that has a lot of the resources that I'm going to go through quickly here because you can look at them yourself. And so the first thing they do is a readiness assessment. And I'm going to try to kind of like pound this in, the fact that men need an MRI. And it's awful to have a horrible disease and know you couldn't have done anything about it. It's even worse to have an awful disease and think, if I had just gone in 5 years earlier, I had this information. It is, it's a horrible situation. And it's not fair because they're young adults and we all make bad decisions as young adults, but we have to, clearly, Kathleen's looking, but we have to give them the chance and we have to make sure they realize that they need those MRIs. And so once we can kind of understand where the needs are, do they understand their medications? Do they have a provider? We can look at developing a care plan. And so I just put a few of these in as references. So there are legal considerations. You obviously need health insurance in order to continue to get care. Laws and even the age of reaching adulthood vary by state. And so Autism Speaks has already done a very nice job of putting together a web page where you can click on your state and find out how to get guardianship in that state and what the paperwork and laws are around it. And then the other thing to mention is that for our kids that are getting physical therapy or occupational therapy at school, as they go into adulthood, that care needs to become part of their medical plan, even if it was originally part of their educational plan. Okay. And so then medications. And so I don't know that I do as good a job of this in our leukodystrophy clinic, but I know in my ADHD clinic, I do spend a lot of time talking about the importance of teenagers learning to take on their own medicine and being responsible for knowing when to take it, how to take it, and also refills, because a lot of them might take it on a daily basis, but don't think that they need to refill it. And then if I could say like one slide to adult men, what I want all adult men who are getting ready to transition. So the first thing is that this is serious, right? So this is still, I think, very half full. We're going to have lots of good treatment options, but this is not a situation where you want to put your head in the sand and not go to the doctor. And the second thing is that AMN and cerebral disease, we think we can work on this and that there are going to be treatments, but only if we catch it early. And especially with all of these new therapies hopefully be coming out, we don't think, at least I don't think they're going to reverse disease. We think they're going to halt it. And so it's really important that they're taking care of themselves. And then the other thing that I want to make sure they know is that erectile dysfunction and urinary problems are really common in even really young men, and that it's really treatable. And so even if they're 19 or 20, they should still tell us, and we can still work on it. And so then once we have that plan, I put together kind of like, on the right is the list of things I think you really absolutely have to have before your first appointment. And on the left is the things I think would be really nice if you had. So as a reference. So I think if we could have all our men by the time they're going to go to their own appointment, absolutely have everything on the right. And it would be very nice if they could have everything on the entire slide. And then I just wanted to spend a minute talking about why we want your MRI on a CD. Because I think a lot of people think this is just us being annoying. So the first thing is that obviously we can tell way more from your MRI by looking at the picture. But the other is that if this has always been your MRI, you might be okay, right? Just like how my echo had always been like that, so it was okay. But if we only had this one image, we would be very concerned. And so we know that 20% of men get cerebral disease, but there are lots of men we see in clinic that have an old lesion that's already halted. And the only way we can tell that is if we have multiple MRIs to look at. And so then kind of preparing for the first visit, I always tell patients, including parents, to write down your questions. Because inevitably, when you get in front of the doctor, your mind blanks and you don't remember anything that you wanted to ask. So it's always best to have that written down. And it's always good to have a physical copy. And it's important that when we have boys becoming teenagers, that we begin to spend some time alone with them without their parents in the room. So unanswered questions, I think there are many. So do we even understand the needs of our community? I'm not sure we do. Where do we go from here? And then what are your ideas? And of course, I always have ideas. So I did put a few of my personal ideas on here. So the first is, I think there is already these tools that we could just edit that are on that Got Transitions page. I think that we need to educate all of us as providers and try to make it easy for us to actually do it during the clinic visit. I wondered if there was a role for some type of Big Brother program where you would pair some of these adolescents with some of the men. You have plenty of inspiring men in your group and women. And then I also think we need to develop adult centers of excellence. That's all I have.
With all these kids and everything's on basically Epic systems now, as far as medical records, is there any way for patients to access that to see what their records are and make sure that it's there? Because I think we're all just hoping that there's a digital footprint of us. Can we verify that in any sort of way?
So I think the answer probably depends on institution. So it is more and more that we can find your records from other centers. But honestly, the best thing is to just have a copy.